presentar a la doctora Kiran Thakur, que no solamente es una gran amiga nuestra, sino también es una gran colega y gran mentora. La doctora Kiran Thakur es una neuróloga egresada de Harvard, hizo su fellowship en enfermedades neuroinflamatorias y neuroinfecciosas en Johns Hopkins. Actualmente trabaja en el hospital de la Universidad de Columbia como neuróloga, específicamente trabaja en el Irving Medical Center, con un gran interés en infecciones del sistema nervioso central, específicamente en infecciones emergentes y reemergentes con potencial de brote. Thank you, Kiran, for joining us today. This is your great chance to practice your Spanish a little bit. Entonces, sin más preámbulos, empezamos la charla.
Gracias. Yes. I'm very sorry, lo siento, porque hablar en español un poquito. Muy mal. It's such a pleasure to be here, and I'm very sorry. My Spanish hopefully is improving. Carlos and Maria know that I practice in a heavily Spanish-speaking area in New York City, and so you would think that I would be fluent by now, but it's taken me some time in my old age. So I'm going to share my screen. I think that so today I'm going to speak on neurological infections of outbreak potential. This is an audience which, you know, this is near and dear to everybody's heart here. So I feel like I'm speaking to colleagues who understand the importance of this topic. And this will be partly reflective of the past experiences that some of which I've been involved in, some of the present challenges that we've had, and the lessons we've learned around COVID-19. And then I think most importantly, the future challenges, but also the opportunities that we have within this field. So the following are my disclosures. I really want to acknowledge Dr. Pardo. I trained with him when I was a fellow in neuroinfectious diseases and neuroimmunology at Hopkins, and I was with Maria as well. And I think about on a regular basis just the type of doctor he is, the scientific questions that he raised really around patient-centered investigations, and this has really inspired my career over the last nearly decade since I've left fellowship, which is hard to imagine. So I want to take this opportunity to thank him. And this is a really exciting network to learn about, and hopefully we'll form some collaborations in the future. So, you know, again, I think I'm kind of preaching to the choir here, but why should we as neurologists really care about emerging and re-emerging infectious diseases? So this is a map that is developed annually by Anthony Fauci and describes some of the newly emerging, re-emerging, and deliberately emerging infectious diseases that are happening worldwide. And as you can see here, there are a number that are neurotropic or neuroinvasive or systemic infections that have secondary effects on the nervous system, including things like West Nile virus, Lyme disease, Nipah virus, Lassa fever. You know, I think really all of these on this map have some neurological effects, either primary or secondary. And so we have really an important role. And of course, I think the last 2.5 years, really the field of infectious diseases from an outbreak perspective, as well as neurological infectious diseases, has really become of utmost importance as we've obviously been dealing with the horrible effects from COVID-19. So it's not just the acute period, and I always like to emphasize that when we're thinking about neuroinfectious diseases, it's not just the burden of infectious disease itself, but also the secondary kind of non-communicable disease burden, which is often underestimated in this population. So there's a number of secondary effects from neurological infectious diseases, including things like cerebrovascular disease, epilepsy, neuropathy, et cetera. And when you think about conditions, things like Chagas, which is a leading cause, as you all are very aware of in South America, of cardiomyopathy and cerebrovascular events, neurocysticercosis, cirrhosis, which is the leading cause of preventable epilepsy worldwide, leprosy, now secondary to diabetes as a cause of neuropathy worldwide. We'll talk about enteroviruses and myelopathy, HIV and infectious diseases that relate to cognitive disorders. We're learning more about the effects from COVID-19 and headaches as well. So let's start with a case This is a 41-year-old Caucasian woman with a history of Ehlers-Danlos type 3 syndrome, migraine headaches, and sciatica, who received a translaminar epidural steroid injection. 17 days after her injection, she had developed headaches, nausea, and vomiting, and was diagnosed with sinusitis and migraines. She then represented to the hospital 3 days later with fevers, worsening headache, and vomiting. And she also had developed new left face, hand, and foot numbness. Her neurological exam at the time revealed diminished light touch and temperature sensation in the region of her left cranial trigeminal nerve, mandibular division, the left hand, and the dorsal aspect of the left foot, as well as some mild weakness of her left foot dorsiflexion. So she had a very complicated course, which I won't go into in a lot of detail, but had a number of lumbar punctures, as you can see here, during her hospital stay. And you can see here she had an elevated white count from, at the end of her condition when she had been treated, it was 8, but really during ongoing treatment was in the hundreds to 300s, and then a mix of neutrophilic, lymphocytic, and a minor monocytic population. We don't have the serum glucose here, but this was mildly decreased, and then an elevated protein. So as we do, and you all do in the NEAS group, we do an extensive evaluation in these cases. And this patient also was noted to have an acute infarct at the right pons. There was a prominent vessel in the right perimesencephalic cistern, suspicious for a mycotic aneurysm. And then the CTA showed this aneurysm in the superior cerebellar artery. And there was also diffuse vasculopathy, specifically of the posterior circulation. So this was a time period when we were seeing fungal meningitis in the context of steroid injections. And this was actually when I was a fellow at Johns Hopkins. And so there were extensive investigations done to identify that fungal organism, which was identified during that outbreak as Exarchylum. But as was the case in many of the cases, there were negative CSF cultures. The PCR, which had been developed at the CDC and had to be sent out, was negative for fungi and Exarchylum species. And then there was archival CSF that was tested for 1,3-beta-D-glucan, which is Fungitel, which we measure in the blood to detect a fungus. It's part of the cell wall of the fungus. And that had very, very high levels. So that was really the only indication that we had that this was an actual fungal infection outside of the clinical picture and the epidemiological history. So given that information, this patient was started on amphotericin and IV fluoroconazole, which was the recommendations at the time for the treatment. And neurosurgery was consulted. They felt that the risks of surgical intervention outweighed the benefits. An MRI was obtained of the lumbar spine because there was new urinary retention, and there was evidence of arachnoiditis, which was also seen quite frequently in these cases. And extraordinarily, this patient received a total of 32 weeks of treatment. It's just a huge amount of time with lots of side effects from these toxic antifungal medications. Her symptoms resolved 40 weeks after onset, and she actually had resolution of the aneurysm. So she had a good outcome, although in a number of these cases, we did not see the same. So as I mentioned, this was the fungal meningitis outbreak associated with steroid injections that occurred in 2012, 2013 in the United States due to a contaminated compounding agent for steroids that was that was distributed from a specific compounding pharmacy in Massachusetts. And this was the largest healthcare associated outbreak to date, with a total of 753 cases and 64 deaths. And the doses from 3 of the lots from this pharmacy were distributed and administered to about 14,000 patients. So just a huge number in terms of thinking about monitoring for this condition. So as I mentioned in the case, this was not unique to see that, and as we see, and as everybody knows, to see negative CSF fungal cultures, there was really a low probability overall of recovery of the mold. And the CSF RT-PCR developed by the CDC had a low sensitivity of about 40 to 50%, as well as diagnostic delay. So then the question is, well, what are we going to do in real time? Obviously, given the history of steroid injection and the distribution, the vasculopathy that we often see with CNS kind of fungal infections, the diagnosis was, presumed in a lot of cases. But we ended up looking in a lot of these cases at CSF Fungitel to see whether it could be diagnostically helpful, because it could be done quite rapidly in local laboratories. So first we did a series of cases that were negative by culture and PCR initially. Some of these ended up not being the exohyland cases, and those had very low CSF Fungitels, and then the others were positive. And then we went on to do a case control study looking at CSF samples from confirmed cases and control CSF samples, and identified a cutoff of 138, which in the context of this outbreak had very high sensitivity and specificity for the diagnosis of fungal meningitis. Over time, these patients, I think just of note, had a huge amount of adverse events from antifungal therapy, and that was noted at 6 weeks in about 75% of patients on voriconazole and 81% on amphotericin B, just huge numbers. And longitudinal data that showed that 82 patients with meningitis and stroke, 22% ended up dying. So this was not just an acute mortality issue, but longitudinally as well. And, similar to what we see in other kind of post, neuroinfectious disease complicated patients who, may get aspiration pneumonias, et cetera. And then in 7 of the 223 patients with spinal or paraspinal infections that died, 68 had persistent or worsening pain. So again, a huge amount of disability. And what we used with the CSF Fungitel was not just looking at it in the acute setting, but also looking at it as a kind of prognostic tool and looking at it in the treatment course as well, which proved to be quite useful, although it does have several caveats. So these are some of the lessons that I learned, and there were many. Traditional diagnostics for CNS infections due to fungal organisms and atypical bacteria, as we all know, really rarely impact real-time clinical decision-making. And it should really be our priority in diagnostic pipeline development to focus on these agents that we know we don't have good diagnostic tests for. The repurposing of available diagnostic assays and therapeutics leverages opportunities for rapid development and clinical application. And I would emphasize that it should really be thinking about development in labs all over the world. So resource limited and resource rich settings, things that we could potentially apply to at the bedside that's going to have a real-time clinical impact. And, certainly the assessment of this diagnostic assay during an outbreak and has limitations, is suboptimal in ways, but also there's real opportunities for rapid scale up and implementation when we've certainly seen this with COVID-19 in separate circumstances. So I want to go on to West Nile virus neuroinvasive disease. And I was still a teenager at the time that this happened in New York City. But I think just reflecting on it and looking at the literature and understanding the evolution of this outbreak is incredibly important for us to learn some lessons from. So West Nile virus neuroinvasive disease and West Nile virus in general was not known to be in North America at all during this period. And so it wasn't really on the radar of individuals in terms of testing for it. What happened was that in 1999, there were several encephalitis cases that were identified in this small area in northern Queens, about a 16-mile radius. And they were occurring among previously healthy individuals from the ages of 58 to 87 years. And they presented with a febrile illness followed by mental status changes, had findings consistent with encephalitis. They also had flaccid paralysis, which interesting. If you look back at the literature, it describes that they had Guillain-Barré syndrome, when I think we all know now it was acute flaccid myelitis and requiring ventilatory support. So there was an epidemiological investigation, small one at first, of these cases to understand whether there were any common exposures. What they identified was that these individuals, overall were doing like gardening and things like that in their yards outside. And an environmental investigation revealed the presence of Culex mosquito breeding sites and larvae in many of the patients' yards and neighborhoods. So that ended up spurning a widespread effort to eradicate mosquito populations in the city. So for quite some time, there was testing that was done to identify what the actual potential pathogen was. And many specimens were positive for IgM ELISA antibody against St. Louis encephalitis virus, which was a common flavivirus that's zoonotic in North America and that infects human beings. It's overall a very rare cause of encephalitis that we see, but the question was, okay, we know that it could be transmitted by this mosquito population. We know we've seen it here before. So these are likely cases of St. Louis encephalitis. And so if you look at the literature, it really has propagated for quite some time that this was St. Louis encephalitis virus. But what really triggered a big question mark on that was that there was, at the same time, increased mortality of avian species, including crows, exotic birds that were housed in a zoo nearby, our largest zoo in the city. And histological analysis of these birds revealed meningoencephalitis and myocarditis. And St. Louis virus was not known, and I guess veterinarians know this, it shouldn't be infecting these types of species. So then people put a question mark and kind of started to put together the question of whether these cases could be some way put together in terms of what was happening in the species population of birds as well as in the adults. And so 4 weeks after the recognition of the outbreak, in humans, there's flavivirus initially known as initially thought of as St. Louis virus, was then identified as West Nile virus that had affected crows in Westchester County and a flamingo that was at this zoo. And so then studies went on to identify whether in the human cases were actually West Nile virus. And so there was a large citywide effort to do syndromic surveillance on encephalitis cases in New York City. 719 patients with clinical syndromes of meningitis and encephalitis were received by the health departments in New York City, Nassau County, and Westchester County. And in 62 of these 719 patients, so 9%, there was laboratory evidence for recent West Nile virus infection, which is a huge number. And now we see circulating West Nile virus in the city and other parts of the United States, obviously. And not uncommonly do we see West Nile virus neuroinvasive disease in our patient populations that present acutely to the hospital. So what were some of the lessons learned during this outbreak? So one is certainly common cross-reactivity across flaviviruses led to this initial wrong conclusion that results were from St. Louis encephalitis virus. And so pathogen specificity in diagnostic assays overall is a major challenge, especially in this group of flaviviruses, as you know. And I think, again, similar to what I mentioned with targeting pathogens that we have poor diagnostics on, including fungi, atypical bacteria, I think these viruses are also a particular target. I think the emphasis on the importance of zoonotic species investigations that really fundamentally changed the course of this outbreak investigation, I think can't be underestimated. We don't work, I think, enough alongside our veterinarian colleagues to really understand some of the relationships of what they're seeing, and that was really what led to the diagnosis. Syndromic surveillance here of encephalitis was key to identifying epidemiological trends in West Nile virus neuroinvasive disease, although it has real-time limitations. Certainly capturing the cases, reporting them acutely is a significant burden on our clinicians at the bedside. Understanding some of the risk factors from an epidemiological standpoint, et cetera, can be challenging. So I'm going to move on now to acute flaccid myelitis outbreaks. So this was first described 2012, and Dr. Pardo may have already kind of talked about some of this, so I won't talk in too much depth, but there were unusual clusters of this disabling polio-like illness, predominantly in children. That was recognized first in California in 2012 and Colorado in 2014. And it had temporal association, as is shown on this graph on the left, with enterovirus D68 respiratory virus, which was a historically obscure non-poliomyelitis enterovirus. And what these individuals had were these kind of classic gray matter lesions that were longitudinally extensive in their spinal cord And they also had some periventricular signal abnormality as well, and sometimes cranial neuropathies. So now biannually, up until prior to COVID-19, we've seen these biannual peaks of AFM. And so as of October 5th, there's been 22 confirmed cases in this year. And overall, there's been 701 confirmed cases since the CDC began tracking AFM. And there's causes significant morbidity, mortality risk in predominantly pediatric populations, as I mentioned, and you can see here some of the deformities that exist in these populations. So what has been challenging has been how to identify what the actual viral trigger is. So CSF is oftentimes not useful in terms of identifying the virus, and looking for enterovirus D68 has proven to be challenging in CSF samples, including, PCR testing. Oftentimes these patients are coming in, after a hyperacute or acute period. There's often delays in diagnosis. And so one thing that the Center for Infection and Immunity did here at Columbia with myself and CDC is we looked at enterovirus D68 specific peptide array assays. And you can see here we looked at AFM in a small cohort of patients, non-AFM controls, Kawasaki, and then other neuroinflammatory and neuroinfectious diseases. And we were able to assess that there really was this antibody response to enterovirus D68 in a number of these patients. So certainly I think we have a clue that there's a linkage, although, this is complex. There's been other etiologies that have been identified, including other non-polio enteroviruses as well. So one thing that was captured by the AFM surveillance program by the CDC was a recent poliomyelitis case that we had in New York City recently in July of this year. And so initially this patient was reported to the New York City and New York State Department of Health, and then the CDC, and there was detection of poliovirus type 2 in stool samples. This was an unvaccinated, immunocompetent 20-year-old adult who was from just northwest of the city, in an area in which there's a lot of unvaccinated individuals. And he had presented with acute flaccid weakness that ended up being a classic presentation with neuroradiographic findings of acute flaccid myelitis. The patient had initially experienced fever, neck stiffness, GI symptoms, and limb weakness very 2 or 3 days before the onset of weakness, where this systemic symptoms. And that was a clue that this may not be something that was like post-infectious. So the patient was hospitalized for possible AFM and underwent, an extensive workup as we do, including things like looking for things like West Nile virus antibodies, other enteroviruses. And what was identified that there was a vaccine-derived poliovirus type 2 virus that was detected in stool samples that was obtained on day 11 and 12. And this is just the timeline. So this individual had attended a large gathering 7 days before the onset of symptoms. Day 3 was the onset of limb weakness after this onset of this viral prodrome and meningitic symptoms. On day 5, the patient presented to the emergency room and had an extensive workup and evaluation done. And then on day 11 and 12, the stool samples were collected. The patient then was discharged to rehab. I think something just of note here is that this was really captured because of surveillance programs. And so something that I think is really useful to recognize is that the syndromic surveillance really helped in terms of this effort. So what this case spawned was a lot of public health investigations to, one, vaccinate a community which was at risk because a lot of the local population was unvaccinated, but also to think about whether there may be any other cases. So there was certainly education and public awareness campaigns. All of the neurologists in the city and the state were notified to be on the lookout for possible polio cases. Thankfully, we haven't seen any more. And then there was wastewater surveillance done. So environmental surveillance has been a key component of what this diagram is showing on the left, which is the Global Polio Surveillance Action Plan. And this is a global effort to eradicate polio that began in 1988. And there's many components of this. One is environmental surveillance. Another is a network of laboratory facilities. Another is acute flaccid paralysis surveillance. So they're not surveilling acute flaccid myelitis, but the paralysis itself. And this is also global, so it's many resource limited settings. And the environmental surveillance is really around looking at wastewater to identify whether there's any evidence of poliovirus in the wastewater. And why that's important is because if we see that there is poliovirus in the wastewater, it suggests that there is active shedding of the virus and that there's potential for community transmission. And what's been identified in wastewater surveillance in our local area in New York, one in the area of this patient that was identified, but also in surrounding communities, and importantly in New York City, is that wastewater has been positive for this vaccine-derived case. And that means that we have susceptible people who are not vaccinated, young infants who may not have completed their vaccine course, that we have to be concerned about in terms of developing polio. So this surveillance has been ongoing. There's lots of efforts to do this more holistically as well, but I think this is still a story that's emerging. I think thankfully we haven't seen any more cases, which is, I think, a big plus. But again, I think we have to be on the lookout for it. And there's certainly this evidence now because of wastewater surveillance that there's transmission. So what are some of the lessons that are learned here? One is that non-CSF sample diagnostic evaluation is so critical in neuroinfectious disease diagnosis and surveillance, and something I was taught early on by Dr. Pardo, but it does have pragmatic challenges. So, for instance, in this case, collecting stool in a sterile manner by clinicians who aren't always used to collecting stool, it really presents a lot of risk in the hospital setting. And so you have to think about that, educate clinicians, understand how to do this in the safest way possible. Advanced immunological assays, as I mentioned with AFM, are really critical to evaluating for possible infectious triggers, contributing to the neurological phenotypes that we see. And I think importantly, frontline clinicians are so integral and vital to surveillance efforts, though I think the public health reporting system is really incredibly burdensome. Just calling a public health agency here in New York City takes, maybe over an hour to initially report. And oftentimes we don't really have that time. And so there's a huge amount of underreporting that occurs with certain conditions. There's also a lack of awareness overall of what is reportable or should be reported. Large multi-center networks, as we've seen with AFM here nationally, and now your network NEAS, working alongside public health agencies are really critical to monitoring and identifying neuroinfectious diseases of public health significance. So I'm not going to dwell on this because I think you all are experts of Zika virus, but Zika virus happened when I was in my first year as an attending up in northern Manhattan, and we have a large Dominican population, as I mentioned during the first part of this talk. And so we had a large population of individuals at risk. And luckily, we didn't see, much neuroinvasive disease of Zika virus, but we certainly have a lot of people traveling back and forth. And really, it hit us very hard in terms of trying to understand how to monitor for Zika virus, especially in our pregnant female populations, as I'm sure you had to deal with completely on the ground, immersed in this. So what my role included was really around public health activities. And we drew together, and this was with Dr. Pardo and others, guidance on the assessment and management of Guillain-Barré syndrome in the context of Zika virus infection. And what we were lucky about this is that we were dealing with a condition that had a case definition. So there was a Brighton collaboration case definition that was very specific, clearly guided, that we could use. And there was some baseline incidence data. And we could also leverage the acute flaccid paralysis data of the poliovirus network globally to understand baseline incidences and whether those were changing with Zika. There was also clear management guidelines on Guillain-Barré syndrome, which were already developed. And so it was actually quite an easy guidance to develop because of all the existence of these materials. But I think importantly of note, this paper, so this graph, which, we all know, right, showed the initial, this is data from French Polynesia that showed this data from, March, April of cases of Guillain-Barré syndrome that were 20 times higher and had Zika virus associated antibodies from the kind of baseline incidence. It took us 6 months to write these guidelines. And I think I'll talk about this in my kind of lessons learned, but just the striking delay that occurs between clinical observation at the bedside, what we deal with in the acute setting of understanding what we're seeing on a kind of sub-national scale, and then the development and guidance that happens kind of globally or nationally really is striking. And I think Zika virus was a key example of this. I think this also happened with Zika virus congenital syndrome. I will never forget the meeting I was in very early on after papers were emerging around microcephaly and having people very much focused on the fact that we should be developing microcephaly guidelines. And so if you look early on in the Zika virus literature, a lot of it was focused on assessment of microcephaly. And I think for all the pediatric neurologists who are listening on, of course, all of us were banging our heads saying, this is not just microcephaly, this is going to be an entire congenital syndrome. These kids may not have microcephaly, they may have malformations, they may have other findings. And so it took a lot to kind of come to the table and understand that and have others kind of understand that very early on. And of course, that's emerged over time. In terms of long-term outcomes, again, I won't really kind of dwell on this, but certainly there's this huge burden in terms of delayed onset of neurodevelopmental disabilities, 70% at least having complications that we see with these neurodevelopmental abnormalities, including things like epilepsy, pneumonias, recurrent UTIs, dysphasias, risks of aspiration pneumonias, hip dislocations, and sleep disorders. I don't think overall we do enough in neuroinfectious diseases and neurology to try to figure out how we can prevent and monitor those conditions. So I mentioned here, the major delays in recognition of these neurological conditions that impacted public health response. I think that was a major challenge here. Our knowledge on baseline incidence of neurological conditions is so fundamental to identify epidemiological patterns of concern. Although, as I mentioned, I think there's these huge gaps in how we actually monitor for diseases in the public health setting. Community engagement is such a critical component to scientific and public health response to emergencies, and we really focused on that in our Northern Manhattan community. And then I think there's further emphasis that's really needed on longitudinal cohort studies to inform longitudinal outcomes and supportive management needs. So going on to COVID-19, obviously I could talk about this for an entire day, but there's a lot that I think we've learned and we're learning around the COVID-19 pandemic, unfortunately. During the time that we were looking at cases, we were hit incredibly hard in New York City in the spring of 2020. And I'm a neurohospitalist as a clinician, and so I was working in the hospital a lot during that time. And so we very early on were monitoring neurological conditions that we were seeing, although, we weren't seeing patients in person oftentimes. We were dealing with just emergencies coming and going. We weren't doing LPs or neuroimaging routinely as we would have done. And so there's some real limitations in that data. And then we kind of went on as the pandemic continued to do vaccination surveillance in collaboration with the CDC. and then also looking in the Omicron peak at neurological conditions in the context of COVID-19 variants. So this was from our work that we put together, which was a case control study looking at individuals who developed neurological conditions. And one of the things we wanted to emphasize, which we saw acutely, and I didn't think the message was really getting out, is that, you know, as we know as neurologists, oftentimes the neurological conditions that we see may mask what people were screening for in the acute setting. So, you know, we saw a huge amount of encephalopathy, very early on with COVID-19 that was masking other symptoms, including respiratory distress. Ischemic stroke. So we had a lot of patients coming in with acute stroke, hemorrhages and seizures, as you can see, but really predominant was this like kind of encephalopathy that was likely multifactorial, right? I think it was from hypoxia. It was from, you know, kind of toxic metabolic derangements that we were seeing, as well as the infection itself. So I thought, and this was also, I learned from Dr. Pardo, there was two things I wanted to look at in this that I thought I could potentially answer. And one was to ask the question and try to answer, okay, do we see this as a direct CNS infection in COVID-19? And as I said, we really at the bedside, we were hearing that early on, like, oh, this patient has COVID-19 encephalitis. But we said, well, what does that mean? And how do we know it's encephalitis? Like they're just, you know, their SATs are, you know, they're hypoxic, really, really hypoxic and confused. And so how can we tease that apart? And so there's two ways, right? All of us look to see whether we can find a virus or an infection in the central nervous system. And one is looking at the CSF and the other is neuropathology. And so we did both of those. We looked at CSF SARS-CoV-2 RT-PCR in a subset of our individuals and found negative samples in all of them. But that had caveats because, you know, maybe it was not detectable. We haven't validated the RT-PCR. You know, there was the LP was done at various time points from initial infection and development of neurological symptoms. So had a lot of issues and caveats, although I think now we know there's a lot of literature that overall CSF RT-PCR is negative, consistent with a lack of like direct CNS infection. And then we did a neuropathology study on 41 brains that had COVID-19. And so we looked at a number of things to identify virus in the brain. One, we looked at the RT-PCR. And what we did was, because we knew that the PCR was also measuring the blood in the tissue, we wanted to kind of compare it in terms of the cyclothreshold values to what we were seeing in the nasal swab and also the nasal epithelium, because we knew those were kind of floridly positive. And so if you see here on the bottom right, you can see overall, we had very mildly positive to negative results of the RT-PCR here in our in the multiple brain samples that we did. We also did RNA scope looking for viral RNA. And what was nicely done is I think that we paired our samples in our patients with lung samples. So you can see here this kind of pink color on the RNA scope data is positive. And then these were the multiple tissue samples, and we didn't see any positive findings. Also on immunohistochemistry, we didn't see any positivity for SARS-CoV-2. What we did see was evidence of some inflammation, and I'll talk about that in a second, but we did see some kind of microglial activation. So this case, I wish we had had time to write it up separately, because I think it was such an interesting case to look at from a neuropathological standpoint, in contrast to kind of pure COVID. So we happened to have this case of disseminated herpes simplex virus 1 that involved the brain. So they had HSV1 encephalitis. It was a post-transplant patient, very, very sick. They also had COVID. So they were in the ICU, hypoxic with COVID, but also had disseminated HSV. And on autopsy, had clear findings related to HSV1 encephalitis, including viral inclusions. And so we had almost this like intrinsic control looking at a kind of classic encephalitis case versus cases that were COVID-19. And what we found was a number of kind of contrasting features. One is that the HSV-1 encephalitis case had large perivascular and intraparenchymal T cells and macrophage infiltrates, in contrast to a modest level of lymphocytic infiltration in the COVID-19 brains. There were fewer lymphocytes in the choroid plexuses from the lateral ventricles, except in this HSV-1 case, which contained a huge amount of prominent T cells and activated microglia. And then the expression of tight junction proteins, which I'm not showing you here, but the expression of tight junction proteins in the choroid plexus epithelial cells were intact, with the exception of this HSV-1 case, where tight junction staining was completely lost. So all those classic things, and Carlos, you could speak to this maybe later, all those kind of classic findings we see with a viral encephalitis were really missing in the non-HSV-1 case. And I thought that was just beautiful to see. It was something we talked a lot about in real time during this time period as we were learning. So in terms of the kind of immune-mediated pathology, I'm not sure I should say immune-mediated, but I guess what we saw in terms of potential immune-mediated pathology included diffuse microglial activation. And this corresponded, I think, importantly to areas containing hypoxic damage or infarcts. We saw microglial nodules and neuronophagia, most prominently in the brainstem. But I think importantly, we paid very specific attention to go back and try to look for virus, and we couldn't find viral RNA or protein in these regions. There was very sparse perivascular lymphocytic inflammation and infiltration into the brain parenchyma, and also scant lymphocytic infiltration, predominantly around the vessels. So this, I think, is a nice study. It's a smaller study of individuals that had COVID-19, died of COVID-19. They had non-septic controls, and they had a group of individuals who had sepsis. So not COVID-19, but other causes of sepsis. And what they found essentially is that the extent of microglial activation and those inflammatory changes that we saw in COVID-19 were similar to what they were seeing in those non-COVID-19 septic patients. And so what I think the conclusion overall is, in my opinion, is that we're seeing an end result of a process that is not specific to COVID-19, but is giving us a lot of information and knowledge on what happens in hypoxic ischemic damage to the brain, as well as what happens when you have a systemic infection that gives this kind of florid cytokine response and hyperinflammation systemically, and what happens to the brain. I think that's fascinating, but I think that there's not any evidence that we have clearly that COVID-19 directly is triggering these events in the brain. So what are some of the many lessons that I've learned? I think that COVID-19 to me serves as a model to understand the role that systemic infection plays on the nervous system, both in the acute and in the long term. I think we have to be, I mean, we've all seen this, right? We have to be really careful to name a virus neurotropic or neuroinvasive. It has significant implications. I think there's a huge role that inpatient neurologists play in disaster preparation. And I think what we've also seen is just this rapid acceleration that can occur, not just with vaccine development, but also with antiviral treatments, immunomodulatory therapies, which we're hesitant to often use in infectious diseases, and just this like broad opening up of the field in terms of potential therapies, which I think is really exciting and we can leverage for neuroinfectious diseases. So I want to just spend the final few minutes talking about what I think is the future in terms of emerging and re-emerging infections and all the work that we're doing. You know, one, there's this kind of emergence of factors that lead to the emergence of outbreaks. And these relate to the host, the agent, and the environment. And so, you know, there's certainly a number of mutational factors, as we've seen in the host and the agent. There's genetic factors, et cetera. And there's also, I think, really importantly, the environmental factors, which I think are going to kind of explode in the trigger and cause of emerging infectious diseases and neuroinfections in the coming decades. I think specifically the risk associated with vector-borne diseases is just massive, as you all know. And so climate change is driving a number of changes that relate to vector-borne diseases, including the expanded geographic range, the changes in vector behavior, reservoirs are changing in terms of where it is, the affecting of transmission and susceptibility. And all these factors merge, I think, to really put populations which are immunologically naive to these infectious diseases at the forefront of risk. So in terms of major categories of neuroinfectious diseases of emerging threat, and this is somewhat opinion-based at the top, but I think that some of them include arthropod-borne infections. I think there's this expansion of ecological niches that we're seeing. I think probably one of the biggest challenges of the next couple decades at least is going to be multi-drug resistant organisms with neuroinvasive potential, and including multi-drug resistant tuberculosis and bacterial meningitis. I think that's going to be a major challenge of our time. Certainly, we know that infections that can rapidly transmit, like COVID-19 and other respiratory infections that have the potential for neurological consequences, are going to be a significant threat. And there's no doubt, I think, that we'll see ongoing peaks of things like influenza virus. And certainly we've talked about enteroviruses as well. And then WHO has listed some of their top emerging infectious diseases, as you can see here on the bottom. And certainly, I think you can look at all of these and understand that there's either direct or indirect neurological consequences. So I think our role is really relevant in terms of this field. And there's also recent headlines. So we talked about poliovirus. There was a recent outbreak of Japanese encephalitis, which was blamed on kind of climate change. We've seen recent pockets of Eastern equine and Powassan virus in the Northeast. And so we have to be kind of constantly looking for these things and being on the lookout. So what are some future challenges? I mean, there's a lot. So this is very overly simplified, but I think the lack of overall seroprevalence studies and studies on baseline incidence of neurological conditions, specifically of meningitis and encephalitis, is really challenging for us to even identify whether there may be outbreaks. Coordinated monitoring and early detection systems are really lacking. You know, we just now got over in New York City the monkeypox outbreak. And it was just a lesson in the fact that we have a failed public health system, essentially, that's unable to capture, monitor, detect, rapidly treat infectious diseases. And something has to change. This gets even more complex across borders. Clinical evaluation overall and approaches to presumed neuroinfectious diseases are highly varied. And over half of the individuals that we see have an unknown etiology. And I know there's a lot of work being done in NEAS around this. I think this becomes a challenge, especially as we start to see more people thinking about autoimmune etiologies, which is certainly important. But we can't forget that there's kind of both etiologies that we need to evaluate. How best to do so, I don't think we've sorted out. You know, we kind of do this shotgun approach of thinking about different diagnostic tests, and it's based on, you know, the attending you have on service or colleagues that say, well, why don't we test for this? Or we have this entire spectrum of sequencing that we do, and we have results that may be helpful, but I think in pragmatic purposes, it's not really applicable for kind of real-time acute care. Surveillance tools, I think one exciting arena that we have here is the use of potential big data and this emergence of our electronic health record system. But this is really only relevant to resource-rich settings. And there's huge gaps in resource-limited settings, especially in areas where we know there's this kind of high risk of occurrence and emergence of these infectious pathogens. What about future opportunities? So I think there's now a lot of public attention, political will. There's more funding in the area of epidemic and pandemic preparedness. I don't know where that puts us in neuroinfectious diseases, but I think it's opened up the field. certainly there's novel diagnostic platforms that are able to detect emerging pathogens, though I think a lot of further studies need to be done to define clinical implementation. As I mentioned, we have these integrated electronic health records. And so where available, we can do data-intensive neuroinfectious disease surveillance. And I think this age of repurposing and rapidly accelerating diagnosis and treatments is so important to leverage in this kind of like COVID-19 period, because we've seen it done and we've seen it done effectively. And I think that's the biggest lesson we can learn in neuroinfectious diseases, that we shouldn't be afraid to kind of try these things and try to rapidly accelerate them, as it's so important. But I think we'll have to work very collaboratively in order to do so. We can't work as one center. It has to really be large networks that leverage these activities, because overall what we see in New York City is a rare number of these conditions, even though we're kind of a hotspot for infectious pathogens. But partnering with other sites, as you're doing in Colombia, is so incredibly important and valuable. So I want to thank you for listening, and I'm sorry again for my lack of Spanish. Hopefully I'll learn next time we see each other, but it's been a pleasure to speak to you.
Thank you so much, Kiran. That was fantastic. I learned a lot from your talk, and that was an excellent review. We do have some questions in the chat. I think they're in English, but the first one is from Lira Osorio, and it's, what neurological signs and symptoms point towards an infectious cause rather than non-infectious? And this is actually coming in the context of the epidemiology side of the surveillance that we have within NEAS. So looking at things that we should focus on.
In general, or with like specific neurological symptoms?
Yeah, I guess what neurological signs and symptoms would suggest that something is more likely infectious.
Yeah, it's interesting. I think if you look at some of the kind of immune mediated causes of encephalitis, for instance, they often actually have a viral prodrome. So I always teach the residents this. I'm like, because it's like you go down, you hear that someone had a fever or myalgias, and you kind of are like, oh, that's got to be infectious, right? But I always say, well, we have the best literature from NMDA, right? Where it's, there's 60 to 70% of individuals have this viral prodrome. So I don't think that necessarily like negates the fact that it could be infectious or it can be autoimmune. I will say that I think for me, just from like a pragmatic clinical standpoint, I think the timing of it is very helpful. So for instance, in that polio case, we saw a very rapid onset of neurological symptoms after a viral illness. It was, if it's within 24, 48 hours, to me, that's like para-infectious until proven otherwise. I think the existence of clear meningitic symptoms can be incredibly important. So these autoimmune cases oftentimes, and I'd love to hear from Carlos and others, they often have this kind of like general viral prodrome, right? But they don't have that kind of meningitis that we typically see clinically. And then I think it's certain clinical radiographic symptoms or signs that we look for, right? So for instance, when we're talking about like AFM, for instance, and we look at spinal cord pathology, certainly when it's more like immune mediated, it's going to involve more of the white matter and be kind of more patchy oftentimes. And so that can often be helpful as well. I'm not sure if I'm answering that question like appropriately, but
Yeah, let me try to translate that. La pregunta de la doctora.
Oh, sorry, I'm so sorry, I forgot.
La doctora Lida es qué signos sugieren enfermedad neurológica infecciosa versus no infecciosa, y la doctora Kiran empieza por decir que recordemos que en las causas de, por ejemplo, encefalitis autoinmune frecuentemente vemos prodromos virales o síndromes que parecen infecciosos antes, entonces recordar que la presencia de eso no necesariamente nos dice que es autoinmune versus infeccioso. Y ella dice que una cosa importante para notar es el perfil temporal, o sea, qué tanto tiempo ha pasado desde esos síntomas que podrían sugerir una enfermedad viral y el inicio de los síntomas neurológicos. Entonces, si hay algo que es de inicio muy rápido después de los síntomas infecciosos, como por ejemplo 24 o 48 horas después de un síndrome viral. Eso sugiere más que eso es parainfeccioso o infeccioso, versus una cosa más autoinmune que puede ser más varios días o semanas. También menciona que cuando el paciente tiene síntomas claros o signos claros de meningitis, eso suele sugerir más que hay un componente infeccioso, y pues también la presencia de signos radiológicos específicos. Y pone el ejemplo de en mielitis flácida aguda o AFM, donde vemos más involucrada la sustancia gris, que es algo que vemos más en enterovirus, por ejemplo, que en enfermedades autoinmunes donde más comúnmente vemos la sustancia blanca afectada. I think that's, I think I did a fair job. All right, Maria, you're up.
And then the next question, Kiran, and I'll try to give it an infectious spin. So this is Edwin Rosales that is writing from Nicaragua, and he initially says, thanks for the great presentation. And he has a question with regards, when you're thinking about these acute psychotic episodes or patients versus limbic encephalitis. And I think that here, for instance, we have the psych unit also within the ER. And very often we get consulted just to see if those patients that are getting psychotic are because they have an HSV encephalitis. So how do you usually tell those apart? And what are the repeated CSF value in these cases, or the CSF itself, if it's available or not?
Yeah, that's interesting. You know what, I'm happy to share this with you guys. We're trying to pilot. It comes up as a triaging issue, which I have to deal with when I'm an inpatient neurologist. So we started to develop this algorithm to try to help in terms of screening this, because it comes up all the time in real-time clinical practice. So I think the things that help me are, we just talked about a viral prodrome. Certainly if you're seeing like first-time psychosis in an individual, unless it's like related to drug withdrawal, right? And they may have, some symptoms like autonomic symptoms related to that. It's really in that if they have a viral prodrome prior to the onset of their acute psychosis, to me, that's a red flag. The other things are obviously some focality neurologically. Any evidence of possible seizures is going to be a huge red flag. Overall, I will say that lack of response to typical or atypical antipsychotics. So what we'll often do here is if there's not any of those kind of clear red flag symptoms, we will do a trial of antipsychotics for 24 to 48 hours. Now, there are non-responders for kind of psychotic episodes in the acute setting, but if they're truly not responsive at all, right, they're worsening in terms of their clinical picture, to us, that's enough of a red flag that we typically say, like, let's do lumbar puncture. And we try to do it pretty fast, like within a couple of days. Those, I think, are the main things that I look at from a kind of just a clinical perspective.
Great, thank you. Entonces la doctora Thakur nos dice que pues, precisamente nos quiere compartir de alguna forma el algoritmo que están tratando de hacer en el servicio de urgencias, porque es una situación con la cual de alguna forma ven con frecuencia, y simplemente es evaluar los signos de alarma o las banderas rojas que tenemos con estos pacientes. Entonces, pacientes que, por ejemplo, tienen un prodromo viral, pacientes que han convulsionado, pacientes que se vuelven refractarios al manejo antipsicótico, incluso por eso ellos dentro del manejo tienen dar manejo antipsicótico de 24 a 48 horas para ver si hay respuesta, la presencia de focalidad en el examen neurológico. Eso los lleva a pensar que probablemente este episodio o brote psicótico sea secundario a una neuroinfección.
Yeah, I guess the only other point, so I guess you mentioned HSV. I mean, HSV to me is something that you really have to think of hyperacutely. So, typically those patients aren't going to have isolated acute psychosis. I mean, that, they have the fever and seizures and that whole kind of full picture, right? So I think that's one thing. Usually what we're doing is we're trying to identify whether there could be like an autoimmune encephalitis versus acute psychosis, just to clarify.
Y la doctora Thakur nos hace la aclaración, o sea, en el caso específico yo le preguntaba sobre encefalitis por herpes virus, ella dice que esto se va a comportar muy diferente y no solamente va a debutar con una psicosis aguda, también va a tener otros signos clínicos como la presencia de convulsiones, que realmente el dilema lo tenemos cuando estamos enfrentados a pacientes con encefalitis autoinmunes versus psicosis aguda.
All right. The next question is also from Dr. Lira Osorio. Could you detail more the community engagement experience in public health emergencies that you mentioned? For example, the approaches and what works and doesn't work in your experience.
So that's a great question. So, so I think there was a lot that went wrong, at least locally here with Zika virus. People felt very scared and isolated. There was a lot of stigma associated. So I think that the public health messaging, like at its most fundamental level, has to be in like kind of small, community-based, often faith-based settings where people feel like they can be heard. And kind of the bigger approaches we have found really ineffective. So we can start there. There's many more points I want to make. I mean, I think, yeah, I'll stop there and then you can translate, but there.
Okay, so la pregunta de la doctora Lida es que comentara más en el rol de la comunidad y la comunicación con la comunidad en estos escenarios de infecciones emergentes y qué ha funcionado y qué no. Y nos dice la doctora Thakur que va a empezar por mencionar que ha habido muchas cosas que de pronto se hicieron mal o salieron mal durante la experiencia de Zika, por ejemplo, donde la comunicación resultó en estigma acerca de la enfermedad y mucho miedo por parte de la comunidad y que creemos que la comunicación pública debe ser quizás más dirigida en escenarios pequeños en la comunidad donde las personas tengan el chance de ser oídos y comunicar sus preocupaciones.
I think the other point I want to make, so we have a study that's going on right now of it's sponsored by the CDC. And so we're doing, and all the patients that were hospitalized or some of the patients that were hospitalized during the initial surge of COVID-19 in our local community, we're following them up. And about half of our participants are Spanish speaking. And I will say that I'm not actually leading that arm because we have a lot of community health workers. We have Spanish speaking research team members that are so fundamental. And I think that that's really important just to have that communication relationship. And it has, I think for a community-based project that, a lot of people are doing that in our area, but I think that we've learned a lot from having community individuals embedded into the study team is so vital to actually doing it effectively. So.
También la doctora menciona que, por ejemplo, ahorita están conociendo un estudio en colaboración con el CDC en pacientes que fueron hospitalizados post-COVID y que la mitad de los pacientes hablan español. Entonces ella pone el ejemplo de que, por ejemplo, ella no es personalmente quien está dirigiendo esa rama con esa mitad de los pacientes, porque han encontrado que tener individuos que hagan parte de la comunidad que está siendo estudiada como parte del estudio en realidad mejora la participación y la comunicación, entonces que están usando más personas que hablen español dentro del equipo de investigación con esa comunidad.
And we're switching gears a little bit, and the next question is a little bit of a hot topic. So Dr. Andres Villadona says, great talk. I have a question regarding COVID-19 neurotropism. Some authors have described the term long COVID, which includes a variety of symptoms in different systems and includes neuropsychiatric impairments. Do you think it's accurate to talk about long COVID? And if so, do you think there is any physiopathological explanation of these disorders?
Yeah, I mean, I don't like the term long COVID. That's one, because it makes it sound like there's ongoing infection. So I think that it's really like post-acute COVID, right? They've gotten over the infection, but there's something. I think it's certainly it's real. it's something that we need to understand further. A lot of the data is qualitative. There's now quantitative data emerging. But I think what we've seen, at least in the studies of the initial acute period of COVID-19, is that it's not from the virus directly affecting the brain, but these secondary effects. And there's different populations, right? So there's people who are in the hospital, severely sick, hypoxic. We know that people who have sepsis and hypoxia develop an encephalopathy. So that is, and have cognitive impairment longitudinally. So that's of no surprise. And that's related to kind of inflammatory factors. And then there's the milder COVID patients, and there's likely some interaction, right? And there's been studies showing interaction between the systemic symptoms and what happens, you know, in terms of systemic inflammation and the response in the brain.
Thank you so much for that. No, it's okay. Y la doctora Kiran hace un resumen muy interesante al respecto de la pregunta y nos dice que realmente el problema de tratar el término como un long COVID es que de alguna forma infiere que hay un proceso inflamatorio infeccioso crónico, que ella incluso preferiría que esto se llamaran infecciones posagudas de lo que tuvieron estos pacientes en COVID. Fisiopatológicamente es difícil de entender, de todas formas es un fenómeno que es real, que estamos viendo en este momento con nuestros pacientes en neurología. Sin embargo, las publicaciones iniciales nos daban datos muy cualitativos, ya en este momento están emergiendo algunos datos cuantitativos que probablemente van a tener también mejor calidad y a pesar de que no hay un efecto directo del virus, se sabe por lo menos de otras patologías que personas que han estado críticamente enfermas por otras causas que no son COVID también van a presentar algún deterioro cognitivo o encefalopatía posterior a estos eventos, no necesariamente es con respecto al virus. Sin embargo, hay pacientes con enfermedad leve que tienen activación o marcadores inflamatorios sistémicos que están teniendo algunas manifestaciones. Entonces, se vuelve un área todavía de investigación activa.
All right, and the next is just a comment saying, thank you so much, excellent conference, congratulations. That's by Dr. Gonzalez. And then after that, next question is, in your institution, what is your experience about the use of sertraline in the treatment of fungal infections?
We don't use it routinely for fungal infections. I don't know if anyone else does, but we don't use it routinely.
Entonces la pregunta era acerca de la sertralina, que es un antidepresivo en el rol de tratamiento de enfermedades por hongos. Y la respuesta es que no se usa de manera rutinaria, al menos en la experiencia del doctor.
Muchas gracias, Kiran, por una conferencia excelente y por todas las respuestas. Y siempre está bienvenida a todas las reuniones de NEAS y muchas gracias por compartir la experiencia de Nueva York y toda la experiencia con los problemas neuroepidemiológicos y de enfermedades infecciosas. Thank you so much for your participation.
Gracias.
Thank you, Kiran.
Thank you.
Thank you.